Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. As you know, every week I have a different guest in my program that talks about healthcare services, programs, things that are provided here at KRMC that I think will be of interest to you and your family. I've got a great guest on the show today. We're going to learn a lot. So stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Leanne Strasser. She's the new Director of Case Management here at KRMC. Thanks for being on the show.
Well, thank you for having me.
So let's get to know Leanne a little bit first.
Okay.
I know we'll talk about KRMC's first, but how long have you been in Kingman?
I've been here now over 16 years.
Wow.
Moved here back when I was 16 years old, so.
Very good. So you've seen some changes in Kingman in the last 16 years. We've gone through a lot of changes. And so you went to high school the last couple of years?
I did.
Very good. Through KHS was... Yeah.
Yes, through the little program that they have.
Very good. So then how did you get into working at KRMC?
Well, when I turned 25, I decided I needed a new career, decided to go back to school, to finish college in nursing. So became a nurse extern in 2007, got my RN license in 2008, and have been working here
So you're a nurse first, and then, so you worked on the floors as a nurse?
I did. I was a staff nurse for a few years, and then I got into management in 2011, and have now taken on this new role as the Director of Case Management. So.
Very good. Well, now let's talk about case management. What is, a lot of people probably don't even know, because it used to be called social services.
Correct.
Right? That's maybe what they're more familiar with.
Yes. What case management is it comprises of a set of specialties of a registered nurse, a master's in social work, and then we have discharge coordinators. And what they do is they collaborate together to help with coordinating the care for our patients. From the time that they walk into the ER, we're trying to look and see what they may need when they go home, what's going to best facilitate the best transition there, and just provide services that maybe patients don't realize we offer here in Kingman.
So that's good. We can talk about that, because this is a good way to help educate people before they get here. Sometimes
Absolutely.
it helps for them to know ahead of time.
Absolutely. You know, a lot of what patients don't see is that we offer a lot of assistance for the elderly in regards to Meals on Wheels or
Helping them get set up for that when they get home?
Correct.
Okay.
We also offer here within the community, there are assisted living places if they feel like they can't be at home by themselves anymore. They don't have a family member to help them.
There's quite a bit of that. I know we have a lot of seniors here that retired here type of thing, left the kids back east or whatever.
Right,
And they were in good
exactly.
health when they first got here. And then a lot of times they lose, one of the spouse will pass away and they're all alone.
Exactly.
So they have no one to help them when they get home.
Right. And then we also help set up services for any equipment that they might need for home, as far as whether it's hospital equipment for like a bed and such, or wheelchair. We also help with walkers, oxygen, anything that we find that they may need or they didn't realize that they needed when they go home.
Okay.
We also try to help with organizing maybe just a safety check at home. We send out home health that can assess, you know, are there rugs on your floor that probably shouldn't be there so you don't trip, or
Good
are there
point.
bars that are in your shower that are probably appropriate to help you get in and out of your shower, those kinds of things.
That's good. See, I didn't even know that I learn something every time I do this show. So, and those are things that we kind of take for granted or don't think about when, well, of course, you come into the ER, usually that's not planned.
Exactly.
And then not thinking about when you go home, what you're going to need, what the special issues are going to be for you to be able to go home and be safe.
Well, and I think we forget how much our body needs to take in order to recover from any kind of illness or injury. We all tend to want to think that we can rebound fairly quickly.
Right.
I was healthy,
Yeah.
I'm okay, and
Get me
those
outta
injuries
here.
and illnesses, right, your body needs longer as we age. It needs longer and
Sure.
longer to recover, and thus we're weaker. And so we need a little bit more help. And it's our job to make sure that you know what's available, that you have the help that you need, and that you go home safely and with the services
That's
that
great.
are available.
Well, and like you said, having those options, because maybe they're not sick enough to stay in the hospital and yet not quite ready to be independent. So helping them find a transition, right?
Perfect.
Kind of what you were talking about.
That's exactly correct. We don't always meet the need to be here within the acute care setting, and yet we still have needs that are beyond what's available at home by ourselves.
Right,
And it's
right.
definitely the job of the case managers to kind of help facilitate that transition between here and home. So.
And even transportation, I know you help with those kind of things. If they like live out in Dolan Springs and Meadview and came by ambulance, now how do I get home?
Exactly, exactly. And sometimes it's something as simple as medications that need to be filled. Perhaps it's an issue of, you know, your insurance has lapsed between one company or the next, and so you have that kind of transition time where you don't have insurance, you're limited on funds, and we have ways to assist with that as well. So we kind of look at all
Boy,
of
you
that.
just have this whole big library of.
a nice little array of resources
Right.
to pull from.
So how
within the
do you
community.
have like some kind of a spreadsheet or something? How do you keep track of? That's a lot of things to keep track of.
It is a lot of things to keep track of, and we do actually. We utilize spreadsheets and things like that
Okay.
to monitor where we're utilizing our resources. Are we utilizing them effectively and to the patients that truly need it
Sure.
prior to going home? So
Well, and you figure we have 150 beds, or not beds, but we usually have around a census of 150 now, right?
Correct.
So that's a lot of people.
it's a lot of
That are
people, and that doesn't
moving.
include the ones that come in the ER and need to go home from the ER, and we still help them transition from their ER visit back to home, or maybe they came in from home and it is appropriate for a nursing type home, and we'll transfer it from the ER as well. So.
And that's a good point too, because you have case managers at different levels, and like I know you have a case manager at the cancer center.
Correct.
That is separate as far as he doesn't like get up on the floors too much to care for the patients there. And then you have a case manager in the ER that more focuses just on that area, right?
And then there's a case manager in home health.
Oh,
so
okay.
so they are
Kind of
diverse
different
as far
specialties
as
almost.
Yep.
Hospice, do they have their own case managers?
I believe the hospice and home health are joined together
okay.
for the same case
Okay.
manager, I believe.
Okay, well, that's a lot of balancing for you to do too. That had to have been kind of a big picture to catch right away.
It is. Unfortunate that I don't have to manage those case managers. They're under their own directors in those
Okay.
departments. However, we facilitate, of course, and collaborate
Sure, work
together to make sure.
Right.
Yeah.
So what kind of, now, you talked about you're an RN, so you obviously had nurses training. Then what other training did you need to get into, like if someone's interested in becoming a case manager? What kind of,
Well, in 2011, I went ahead and went from my AD into my bachelor's degree, and
Okay.
decided that, you know, from there, I wanted to go ahead and get my master's degree.
Oh,
so I got my
okay.
master's in nursing, and going from the clinical manager of second floor into case management, I just kind of did a lot of research on my own as far as developing the concept of case management and what did it really entail, and was I interested in that field. And at that point I had decided that to limit the scope of nursing to just one area, which was clinical management of a med-surg type unit. I wanted to broaden that, and that's what case management is. It encompasses the entire continuum of the patient-centered
right, from
care. So-
beginning all the way through?
Correct. So, you know, there is special training out there. There are organizations that you can join. So I joined a couple of two associations, as well as the NASA organization. So became members of those, and
So they're kind of like a networking can share if you have questions or learn from each other. What
Exactly, exactly.
we got to do that in marketing too. They have different groups that you can belong to, and you can bounce ideas off of. Or have you ever thought about, or how did you do this kind of thing?
Absolutely, it is all about networking in order
Yeah.
to find out what other hospitals, organizations have done to better have better patient outcomes. So we pull from that and try to
Sure.
adopt good practices.
Well, and obviously too, then you have to have good communication skills, because not only are you dealing with the case managers and the patients, but then the doctors too.
Correct.
Right, you're kind of the liaison.
We are. We deal with every aspect within the hospital setting. We're here to help everyone, including, not only the patient, but the patient's family and the physicians. We look to physical therapy, respiratory, dietary. So we really collaborate as a whole team.
The whole patient. I mean,
Yes.
the whole body of that
Yep.
patient, looking at that whole big.
The big
Picture.
picture.
That's
Yes, we're
a
not a
lot.
focused care. We're more of
Right.
a broad
Yeah,
generalized.
you're not just looking at the arm.
Correct. Right.
And like I said, with the family too, and we've talked about on the show in the past how when someone's in the hospital, of course, that's unless you're having a baby, it's not usually a good experience, right?
Right. Yeah, nobody wants to be here.
Right. And they're always, of course, anxious to get home as soon as possible. And so I can see the value of what your group adds to, number one, help facilitate that, to get them home or into another facility as soon as possible. And obviously that helps the hospital too, because that opens the bed for another patient that might need to come in.
Exactly.
But helping the family during that transition time, and whether even with a loss, when someone passes away, you're obviously going to be there for that too, right?
Yep. We have to help facilitate all of that. And I think where we'd like to take the pride or the ownership the most is that we're not just worried about transitioning from the hospital to home, but how effective is that transition and the follow-up behind that? Did we do a good job? Did we get you your services that you needed so that you did get better? So we try to pride in making sure that occurs. So.
Well, and another thing we've talked about on the show many times is living in a small rural community like we do, where the people we care for in the hospital are our neighbors and friends or family members or family of friends. And
Absolutely.
it's not like in a big city where you might care for a patient and then never see them again. You're more than likely going to run into either that patient or their family at Walmart or the movies or
somewhere. Yeah, absolutely.
And so of course it's all the more critically important that we make sure they have a good experience, that we follow through with them, because we want them to come up and give us a hug, not a
Right, exactly. Yeah, we want them to still like us.
Yes,
when they leave.
exactly.
Absolutely.
We're going to take a quick commercial break, and then we'll come back and talk a little bit more, Leanne. Thank you. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Leanne Strasser. She's the director of our case management department here at KRMC. Thanks again for being on the show.
Thank you.
So before the break, we were talking about case management and helping people kind of get a better understanding of what that means and how it used to be called social services. I don't think we talked about do you know how it went from social services to case manager?
Well,
manager?
of course, as times change, we become across new evidence and what we're trying to facilitate for the patients. And we went for a more broader umbrella to include nurses. If we say social services, then we think those are just social workers.
Right.
And really, we want to encompass nurses in that as well,
Okay.
along with some discharge coordinators that we've included to help facilitate everything.
So the nurses, are they the ones that are looking at the health of the patient, well, the social, because we still have social workers too, right?
We do. And what the idea is behind is that the social workers and the nurses can kind of do the job interchangeably, but their expertises are, of course, two different scopes. And the social worker really looks at more of the social issues, resources, financial, psychosocial type needs, environmental issues that might
Like
be
we were talking
present.
about making sure the home is ready, safe, that type of
Correct.
thing. Okay.
And then when we think about the nurses kind of look at your health in general and what needs you may have based on symptoms that you might be having, or we can educate in regards to symptoms that you may experience once you go home, or things
Things to
look.
watch for.
Correct.
Okay, very good. So, and that's the case managers, they pretty much touch every patient that comes into the hospital, right?
Correct. We do assess every patient that comes within the facility that's admitted to the facility.
Okay.
How involved we are with each patient does differ depending
Sure.
on your needs.
Right.
If you're a younger person that's come in for a pretty simple reason,
Right.
we may not be as involved as somebody who's in with a chronic illness that needs a
Right.
lot of our
Okay,
attention.
that
So,
makes sense. Now, we also have this brand new unit that we're opening up here soon. What's it called again?
it's the clinical
Clinical.
decision unit is what we
Okay.
decided to call it for our observation patients.
Okay, and that's going to be where our acute rehab is right now, because, well, actually, by the time this show airs, we will have moved, I believe, because June 24th is the big final move of ARU over to HMC, Wallapai Mountain Campus. And then we're going to transition and move the observation beds into where acute rehab.
Correct.
Okay.
Correct.
So you called it clinical
Decision
unit.
unit.
What does that mean?
What that means is that you have presented to the ER with a certain set of symptoms, and I'll just use chest pain as an
Okay.
example. And we have run some preliminary tests in the emergency room. Your symptoms, however, the doc's not maybe very comfortable sending you home because maybe one of the tests came out positive, or you're still complaining of chest pain even though the tests were negative. So we want to monitor you for a little longer length
Okay.
of time. So we will put you and transfer you over into this clinical decision unit, and we will clinically decide if you still need to be here.
Okay.
That time frame may be anywhere between 8 hours and 24 hours. Once a decision has been made, whether you still need to continue to stay or go home, your discharge planning then takes place at that
Okay.
time.
And that helps, then you've made the decision whether they're going to be admitted completely into the hospital.
Correct.
As into the acute side, or like you said, get to go home.
Right.
So that's a good, and they're all kind of in one area. Because I think right now, it's sort of as we have an extra bed open, right?
Correct.
They might be in the ER and the doctor says, well, I don't want to send them home yet, but we also don't want them just spending 24 hours in the ER.
Right, exactly.
I think the beds up on the floors are a little bit more
comfortable.
comfortable.
Yes.
And maybe not quite such a crazy environment going on around you as it is
Right.
in the ER.
Right.
So you have a little bit more.
And I think one of the big advantages to the unit is going to be that the patient will be a little bit more eased to go, you know what, I want to go home, but I understand that they need to monitor me for just a short amount of time, so I'll go home soon.
Right.
And so they get that little bit of comfort to know that, perhaps that they will be going home. A lot of patients have the misconception that once you're admitted, you're going to be stuck here for days.
Yes.
And this unit by no means would give you that impression.
That's good. Now, is that going to have its own nursing staff and everything, just kind of its own separate unit?
It is. It's a unit that will be specifically for observation patients, which
Okay.
will be in the unit, and nurses, CNAs, the
Okay,
unit coordinator will all be in that
But
unit
just
as well.
focused on that particular area. Now, how many beds are we planning, do you know?
20, we'll have
Oh,
a total
wow.
of 20 beds for that
Wow.
unit.
Very good.
Yeah,
So
very exciting.
I guess I just didn't realize there could be that many patients that we have that just need to be observed for a short period of time.
We do. I mean, a lot of times we find, especially with our population, that it's just we want to make sure that they have the best care possible,
Okay.
and that they do go home safely. So sometimes
Right.
we just need to monitor that a
Yeah.
little bit longer. So.
Well, and I would think, like, another thing that case management steps in, we have our care area, if you would, outlying area is quite large, actually. I mean, we go all the way to Peach Springs and Dolan Springs and Meadview. That's a wide, expansive area, and someone going home all the way to Meadview and Dolan Springs, and then you want to make sure that they're going to go home and be healthy and not have to come back in again.
Exactly.
Because that's a long drive back.
Exactly.
have more issues again.
And the patient needs that comfort.
Yes,
You know,
yeah.
they think to themselves, I'm going to have to go all the way home to Dolan Springs where there's not services
Right.
close by.
Yeah.
Am I safe to
Yeah,
go
I don't
home?
even know
So,
that they have a pharmacy out that area, so they have to get everything in town, right?
correct.
Okay. Now, does home, and I know this isn't quite under your bailiwick, but home health, well, you can send someone to help, like with bandage changes, things like that, right?
There is an agency that does service Dolan
Okay.
Springs and Meadview.
Oh, okay,
So
good.
yeah, that is available.
And
to
you work
our-
with them on that side as
We do.
well?
Mhm,
Okay.
absolutely.
And then, of course, transportation, we've talked about, we have the KRMC bus right
Yep.
now that is able to help take patients
Wonderful
back.
service,
Right,
yes.
back and forth, and we're using it quite a bit to bring patients in as well, whether they're having therapy or they're coming in for their cancer treatments, things like that, again, from those outlying areas. And it's amazing how many people live that far out and don't have reliable transportation.
It is.
And that's kind of scary.
It is kind of scary, but I guess for most people, they just like that quiet
Yeah,
atmosphere.
that's the lifestyle they've
and-
chosen.
yeah.
That's fine, yeah. But I'm just amazed sometimes when I hear that they're that far out and don't have a good form of transportation to get in and out. I'm like,
Yeah,
wow.
exactly. There are some challenges that we definitely face, and we try
Absolutely.
to overcome them best we can. So,
And I think, and being, again, a rural community, of course, that is a lot of what we have. And we have Kingman proper, but there is all of that outlying area as well. So it's great to know that we have that facilitator in case management to help them.
yeah.
And I think now with the observation unit, so probably what, mid to late July, do you think they'll be opening?
Actually, it'll be more like late August.
Oh, August,
Yes,
okay, yeah,
yes. We're looking
before-
at August timeframe right now as we look to finalize everything that we need to have done prior
Okay.
to opening, make sure it's successful and
Very good.
and utilized in the best
Yeah.
manner. So.
So are you enjoying this new transition for you?
I am. It has been quite the challenge, and I've
Good.
accepted it, and look forward to moving forward and helping the community and making really a lot of improvements for our patients, needs that we've been identifying that need to take place. And
Well, and it's good to come in sometimes with fresh, new looks from out, kind of more objective maybe. You haven't been doing that specifically, so you have, less jaded maybe.
Yes, yeah.
Perspective.
correct, yeah. I think too is sometimes we become so complacent in our jobs that we can't see beyond what we currently
Right.
do on a day-to-day
Yeah.
basis. So for me, it's just a matter of, have we thought about this and have we thought about that? And has it been thought about? Probably. Just didn't think it was important maybe at
Right.
the time. And so, yeah, it's been great.
I didn't ask you either how many case managers do you have? that are-
Currently in my department, I have 11 case managers.
Oh, wow.
I have 4 discharge coordinators and 1 insurance specialist.
So what does the insurance specialist do that's?
What she does is she looks to help facilitate with the case managers what's needed within the charts for insurance purposes. When a patient is admitted, the insurance company, of course, is made aware, and then they want some reviews on the charts to make sure that we're doing everything that we need to be doing for the
Okay.
patient, and that we're meeting the needs of the patient to be inside the hospital.
Okay, so making sure that that patient is where they're supposed to be.
Correct. Yep, exactly.
'Cause
And then she
sometimes-
sends that information to the insurance company.
Okay, because I know you hear stories from in the past how patients would be in the hospital for long periods of time, and then insurance is like, no, don't think so.
Exactly, and we don't want that patient to have
No.
to incur any
Right.
undue costs.
Right.
So it's definitely looking at all of that to
Making
make
that
sure.
whole thing. So you've got a great team.
I do.
That's pretty awesome.
I do.
And you have all of these that are, they kind of have strengths and weaknesses that balance each other and help them see the whole picture. So it's
Exactly.
pretty exciting. So what do you think is going to happen in your group in the future? I mean,
Well, I am looking to do some different things within the department to kind of hone in on those strengths and weaknesses and to maximize what we offer, and look forward to many new improvements within the department. So.
awesome. Well, we'll have to have you back on the show another time to talk about those improvements.
Great.
Thanks
Well-
again for being on the show, Leanne.
Thank you.
I hope you learned something new. I know I did. We'll see you again next week with another great guest.